First one, true or false? Osteoarthritis is just a wear and tear from aging.
False.
Okay. Number two, can supplements like glucosamine and chondroitin actually help joint pain?
Maybe.
Okay. Is osteoarthritis always painful or can it be silent?
It can be silent.
And number four, what's one habit that protects joints but most people overlook? Hey everyone, welcome to our next episode. Today is my another delight and pleasure to introduce you to my third rheumatologist on our podcast from Arizona. That's Dr. Brittany Panico. So we're not going to get into, the autoimmune conditions, but a very common topic that you and me may have encountered if you're in midlife or later on, but who knows, can affect it or at any age. So, Dr. Brittany, welcome to our podcast, Hormones and Hope. And I would love you to share about yourself, why you are practicing rheumatology or what's your passion. And then we'll get into the deep dive questions.
Yeah, thank you so much for having me. So I am Brittany Panico. I'm a board certified rheumatologist. I have practice locations in a few states actually, but my primary home base is in Arizona. I also practice in Colorado, Oklahoma, and then my clinic, we have offices in Washington and West Virginia. So we have multiple
Wow.
locations. So that's exciting. And I have been doing rheumatology for about 15 years, give or take, with, everything combined. And part of what I really love about it is just seeing the transformation that patients have over time. Just like in endocrinology, you can start off, really kind of not understanding what's happening with your body. And then with treatment and, just lifestyle changes and all that combined, we can really see patients transform. And one of my passions, I have a couple things that I really, really love, but one of my passions is treating gout. And our clinics are a gout center of excellence. And that really goes hand in hand with osteoarthritis. We'll kind of dive in a little bit deeper as we get into the, our conversation. But we're recognizing more and more that more patients have gout than we really are aware of and looking for. And so there's a giant overlap. And not a lot of people pay much attention to gout. It's kind of one of those things that's like, oh, I've had gout, but not really recognizing what that means for the person. So I treat a lot of gout. I treat a lot of psoriatic arthritis, rheumatoid arthritis, lupus, kind of the, normal sort of autoimmune things that we think about. And then there's a few more rare things that my clinic specializes into. But we'll kind of talk about that as it overlaps with some of the things that questions you, I think it's really cool to be able to solve complex problems and have patients' lives actually, improve. That's our goal. So.
Yeah, you're making them, more mobile. Absolutely. So, what we'll start with is I actually tried to add more rapid fire questions for you because it's such a fascinating field, just like you mentioned. So, answers could be yes, no, true, false, or it depends, or if you have a one liner. And then if you wanted to elaborate on that, we could get that going after the rapid fire questions. So, ready? Okay. First one, true or false? Osteoarthritis is just a wear and tear from aging.
False.
Okay. Number two, can supplements like glucosamine and chondroitin actually help joint pain?
Maybe.
Okay. Is osteoarthritis always painful or can it be silent?
It can be silent.
And number four, what's one habit that protects joints but most people overlook?
Avoiding injury.
Number five, true or false? Cracking your knuckles causes arthritis.
False.
Okay. This was one of my most common questions when I was in the process of becoming a doctor, and my relatives used to ask me, "When you become a doctor, let me know if I am cracking my knuckles, will that cause a problem?" So thank you. Number six, should people with arthritis avoid exercise?
False.
Awesome. Number seven, is joint pain always arthritis or could it be something else?
It can be something else.
Okay, thank you very much. Now, you told us about the passion that you have and the numerous forms of arthritis. So, with this question, like our first deep dive question, could you tell or help our audience understand what is arthritis, and then what is osteoarthritis, and how osteoarthritis is different from other forms of arthritis like lupus, rheumatoid arthritis, gout, based on your experience, anything relevant to clinical scenarios or even patient findings.
So, one of the first things if a patient comes to see a rheumatologist, we try to decipher, do you have what we consider inflammatory arthritis or non inflammatory arthritis? So, much like that boundary between prediabetes and overt diabetes, right? That line can be really fuzzy sometimes, but we look for signs of inflammation within the joint itself. That's called synovitis. And that typically happens from your immune system causing inflammation signals that target the joint. So your immune system can actually attack parts of the joint, so either the cartilage or ultimately the bone if it continues long enough, or even the tendons. And so you look for signs that there's inflammation driving this process. So that can either be your immune system, like rheumatoid arthritis, or it can be something obnoxious like a urate crystal, uric acid that triggers gout, or calcium that triggers pseudo gout. Or psoriatic arthritis is actually tendon, but it can involve the joints as well. So it can be both. So when you asked, like, is it always joint pain? Stiffness can be the feeling that your joints are painful, but it might be around the joint, the area. So it can be both. So those things cause inflammation that we can block with medication. So just like how insulin lowers your blood sugar, right, to help control your diabetes, we use what we consider disease modifying agents or DMARDs or biologics, which are typically like injections, to block those inflammation signals so that your body stops essentially eating away at your joint spaces. So that's autoimmunity. That's what we specialize in rheumatology. Osteoarthritis is the wear and tear of a joint structure over time. So it can happen really at any age. As your bones are developing in adolescence, you don't really get osteoarthritis because the bones are still moving and forming. But once that process stops, our bones are always changing, right? We know that with osteoporosis, that there's absorption and development of bone. But when the cartilage breaks down, much like our tires break down as we drive our cars, your body doesn't replace that. And so then when we think about like people hear this term bone on bone. So what does that mean? It just means that the joint space that's like padding and lubricating your joint has worn down so that that space is now much closer together, right? So the fulcrum of trying to maneuver a joint when it's kind of really close versus it's spread apart and it can bend. So wear and tear is osteoarthritis, but also when I mentioned avoiding injury, when you injure an area, like let's say your shoulder or an ankle, right? You break a bone or break your hip. If it's along that joint space, like in the foot where there's lots of joints sitting right next to each other, repairing that is going to change the structure of the bone. So the healing process is a callus that forms, just like how we develop calluses from friction. That callus is not the way your DNA designed that bone to be. That's what happens after you heal. So just like a scar is different than your skin, right? You can see visibly a scar. That's scarring of the bone. And so that new pattern or shape causes then arthritis because it changes the alignment of your the healing process. So when young patients develop osteoarthritis, we typically think of that as a result of an injury. So people who are really rough on their bodies or have multiple injuries, like motorcycle accident, right, where you shatter something, it's really common to develop arthritis because that bone structure has been repaired. It's not the same, right? So when I kind of talk about the tread on a tire, you put a spare tire on, that's typically not always the same size as your normal tire. So you're a little wobbly, kind of. But we don't really think about it that way, and a lot of surgeons don't tell patients that you're gonna have residual pain as your body changes over time. Then, right, in endocrine, you probably talk a lot about weight management. The heavier load that we're carrying, the more pressure we apply to our load-bearing joints, like our knees, our feet. And so, if you're somebody who adds 5 pounds a year, that's an extra load of force that we're applying that then squishes together over time. Gravity is pulling all of that together. So you combine that over 5, 10, 15 years, right? And so now you're putting a lot more load-bearing weight on those joints, and they're wearing just like your tires are gonna wear, and we don't replace them with new joints, and so then we develop what we kind of just every day call arthritis. Osteoarthritis is also very common in the thumb joints, so along the thumb is very common because we do everything with our thumb, so we're constantly moving that joint all day, every day, not thinking much about that. So something where there's a lot of repetitive activity, you can develop arthritis because you're just wearing it down over your lifetime. So when women who, knit or crochet or people who are very intensely use their hands for a living start complaining about joint pain as we age, we associate that with aging because that's how long it takes to develop the discomfort. But the whole process has been going on your entire lifetime because that's what you did with your hands. There's a genetic component. So, like diabetes, right? Some people develop it and some people don't. There's plenty of people who don't have pain in their joints, even though you may look at them and be like, well, why don't you have arthritis and I do? Well, it all depends on your DNA. It depends on how you used your body over the course of your lifetime. It depends on, again, injuries to that area. There's a lot of very subtle things we don't really think about, how many car accidents you've been in, how much pressure or tension you're applying to your body over time, right? A lot of like back and neck osteoarthritis, people think, well, I don't really do things to my body that should lead to it. Well, all it takes is one episode of like whiplash or, doing something in a way that that alignment gets tilted. You may recover from it and think, oh, yeah, I injured my back when I was 20. Like, what difference did that? Well, that subtle shift, right? Just like on your car, again, kind of making this all something that we can see. When your alignment is off, you don't notice it at first until that tire really wears. And then you really blow out your tire and your mechanic is like, oh, your alignment is really off. Well, that's our body. When our alignment gets shifted out of the way our DNA wanted it to be, wears in a pattern over time. And so we don't catch it in the moment, but we catch it when the pain starts or when the irritation starts to trigger a nerve to send pain signals. So osteoarthritis really just means wearing of the joint, and that process happens over the course of time. But we have this idea that we wake up and it is there, but it's been going on for a while.
Yeah. Is there a predominance between is it gender biased osteoarthritis?
Not so much really, I would say gender, because I don't know that we have really attributed specific, like, gender identifying features. We do know there's a syndrome that happens, postmenopausal musculoskeletal syndrome. So women in the perimenopausal, postmenopausal area, a rapid change in estrogen can trigger the sensation of more discomfort and pain and tendon tightness. So we are recognizing that shifts in our hormone levels can contribute to the way our body responds to signaling about pain. But we don't know specifically that more women get arthritis or more men get arthritis. I think we kind of think about it, I would probably say on average, more men are a little bit harder on their bodies, whether that's like sports or work, right? Like construction work where we're really labor intensive. But there's plenty of women who have more hand osteoarthritis because traditionally gender roles you know, varies, right? We're doing things with our hands, and not so much physical labor. But so the joint itself, when we see like an elbow, for example, if you see osteoarthritis in an elbow, that's a very unusual place to have it because it's not a load bearing joint. So we think about like construction workers who are doing a lot of lifting and sort of weird maneuvers or like vibrational, like jackhammering can accelerate arthritis. And so there's peculiar things that we think about when we see it in certain body parts, but there's not specifically like a gender predominance. It's part of being human. that we know of. It's just part of the human process.
Got it. What about fingers? Like when they have joint deformities?
Yeah, so there's different versions of that. So rheumatoid arthritis, we think about having joint deformities, and that's one of the things that we try to prevent from happening because we can actually slow down that process. That is treatable. There's a form of osteoarthritis called erosive osteoarthritis that's a little bit more painful and changes the structure of the bone in ways that traditional wear and tear arthritis doesn't do. And then there's gout. So we're recognizing a lot more that gout can hide on top of osteoarthritis. So we're recognizing a lot more people that we say, "Oh, you just have arthritis," that those patients may actually also have gout, which can irritate the bone and cause inflammation. So, a lot of times it's not just one simple thing, but traditionally, I think we kind of learn it to be that way. But when we're better detectives and actually investigate, oftentimes we can find more than one thing, but not always.
Okay. So that's very well explained. So wear and tear, repetitive, previous trauma or injury, and then the weight that you talked about, and specifically about individual joints that you'll start assessing based on their occupation, and then the genetic component, the DNA aspect of it, and the misalignment. So is there a way? Because we always talk about prevention. Are we all supposed to experience osteoarthritis as we age? Or is there a way to prevent it or slow down that wear and tear?
So we don't really have a way to prevent it or slow it down yet. I know there's different studies, different ways of looking like, can we halt the progression or can we modify how quickly it tends to progress? And as of right now that we know of, there's not a way to do that. Like how in rheumatoid arthritis, we definitely can. So that tends to mean that it's more genetically determined. But also when we think about like nutrition, there's ways that we can alter the inflammation that's in our body through, better gut microbiome and, more pure nutrition rather than like chemically processed foods. So I think it's more along the lines of like, what is going to be healthier for us over our lifetime? Because maintaining a healthy body weight doesn't, again, it's not going to impact the joints in the same way that being 20 pounds overweight would. Controlling your blood sugar, because we do know that there's a component of glycosylation that happens within the tendon structures and even the bone microvascular, like capillaries, right? So the healthier your body is, the healthier your blood flow is, the less damage is gonna happen to those components, like our bone, our joints. It's impossible to avoid all injuries, right? Some things are completely out of our control. So, if you are somebody who has neck and back arthritis because of a car accident, we can't reverse that past for you, but maintaining mobility in your body, exercising. So, exercise is a tricky word for rheumatologists because impact makes a big difference in the way that your bones absorb shock and force, right? So, if you're somebody who's skiing, you're going to have more impact on your knees than somebody who doesn't do that. So, there are plenty of exercise ways to exercise that don't apply impact and force, right? Some people think running, can accelerate osteoarthritis. And we don't really know for sure why certain people experience it and not others, right? There are plenty of marathon runners who will say, I don't have joint pain, but we also don't know how long they're going to be able to continue running marathons. So if you're a marathon runner in your, let's say 30s, 40s, maybe even 50s, when you're 80, which is a natural aging process, you might not be able to keep up either because of pain or just the way your body functions at that time. So we can't predict the future. We don't really know that there's a way to accelerate it in athletes per se, because most competitive athletes also nutritionally take very good care of their body. So we have to think about all those factors, right? You know, I keep relating things to DNA, right? It's how we treat our bodies from the inside out that can modify let's say our parents had diabetes and were very unhealthy, we can still change our genetics and be healthy people ourselves, even though we may have inherited a predisposition for something. So we don't necessarily have to replicate those poor lifestyle choices. So it's a long-winded answer to say, yes and no. We can't stop it. We can't change it, but we can modify our human behavior to decrease the chances that it becomes debilitating for us.
Yeah, absolutely. You emphasized one very important point about, we have the inheritance, right? But there is a lot in our control about the human behaviors that you talked about that can impact a lot of chronic diseases, inflammatory diseases. You are in this field of arthritis or musculoskeletal conditions. So definitely, and in my metabolic world and chronic diseases, definitely a lot more that we can implement. And, it changes every phase of life. It's not that, whatever prevention tools we were using at age 20 and 30 would be the same at age, between that phase of 40 or during perimenopause or midlife for men. They have to change, including the type of exercise or stretches. So you had, when we were talking about a rapid fire, you had mentioned about, two things that I wanted to touch base. One was the overlap of gout and osteoarthritis and why gout is missed out. So if you can, share your insights on that, and we have lots of physicians also in our audience who would love to know how they could take care of their patients or have those conversations with their patients or any form of screenings that you do when you're looking at osteoarthritis, but also suspecting that there might be a second component to their symptoms.
Absolutely. So, generally, when we think about osteoarthritis, we can look at somebody's joint, particularly, I'm thinking about the hands more likely, and say, oh, that looks like arthritis. And we kind of just use the term arthritis. But x rays are a really good tool to telling us what type of arthritis we should expect or should be thinking about. However, I say that with a grain of salt because when we rely on a radiologist to give us a report, right, we have to make sure we're asking the right questions. So when we order tests, we want to get good feedback about it. And so asking, the radiologist, please decipher between inflammatory versus degenerative arthritis changes. And then they give a little bit better explanation versus no abnormalities noted, right? Because osteoarthritis technically is not totally abnormal. It's very common, but we want them to describe what they see because there's a certain pattern that we pick up on to say, well, maybe it could be this. So if you get a completely normal report, but you clearly see a person has like very knobby knuckles, then and is reporting a lot of stiffness and trouble squeezing, right? If a person can't make a fist, that's abnormal. So then you kind of think a little bit, okay, well, what else might be causing that? And it could just be that there's no structural changes to the bone itself yet, but that you're catching it before there's actually bony changes. So that's kind of where gout comes into play. And gout is really tricky because it can hide in plain sight, meaning that patients, particularly women we're identifying, have normal uric acid levels. What does that mean? We rely on uric acid just like we rely on an A1C to tell us the likelihood that you have gout. Higher levels of uric acid, typically 6 and above, increase your risk of gout. 6 and below is kind of like, well, usually we don't think about it, but we actually are recognizing gout in people with uric acid levels even in the 4s or 5s. And we don't know why that is, but we just know that it can hide inside the joints and not really be circulating to tell us that it's abnormal. So sometimes it takes a deeper look, either through something like ultrasound or there's a specialized CT scan called dual energy CT, which overlays a technology that can identify urate or uric acid deposits in that space that you're imaging. So just today, I sent a patient for a dual energy CT of their elbow because, again, there's these peculiar findings that don't quite make sense for just arthritis in the elbow. So we can actually pick up on uric acid deposition if it's there, or look at the tendon structure a little bit deeper. things like that. An MRI, a lot of times we think, well, an MRI will just tell us. An MRI is looking at the soft tissue, not the composition in between the tissues. So you can see completely normal looking tissue with an MRI, but still have inflammation and not have a good, clear explanation for why there's inflammation there. So you might see something called an effusion, which is fluid around that joint space, but it doesn't tell you why it's there. That's where you kind of need your blood work and then, deeper investigation to look into the why. So we rely on blood work to help us identify things like rheumatoid arthritis. We have antibodies in our blood that we can measure, but we don't have a blood test for psoriatic arthritis. So that makes that diagnosis a little bit trickier. And there's a pattern typically of like stiffness that patients have that help us identify that. And then there's also, again, injury inflammation. So if had an accident and that joint is swollen, it's reasonable that their body's trying to heal. And it doesn't necessarily mean it requires, a fancy medication. It can just be part of the injury. So there's imaging that can help us. But again, understanding what images are better than others when you're looking for certain things. And then sometimes there's medications that we can try, short term to see, does this specific thing help you versus steroids, for example. Rheumatologists, we love endocrinologists hate steroids, but rheumatologists, we give them a lot. But the downside to that is it fixes most things. It makes you feel better. So again, don't really understand the why if we just give patients, things like prednisone. So it really, I don't want to just be like, well, you need a rheumatologist to decipher, but it really does take some of those very subtle things to decipher the underlying reason that the pain and swelling is there.
Exactly. Yeah. So this was imaging, and then, of course, like individualized set of labs or antibodies for based on what you're suspecting. What about treatment options? So, just throwing out an example, which is very common, is either a male or a female, and they have knee pain, could be bilateral or unilateral, and it's more conservative management. Is there a step-by-step approach that you do? Like maybe are there any supplements that you prefer versus, any comments about turmeric? I know we had the rapid fire for glucosamine, chondroitin, any other supplements. I've heard about boswellia. So if you can comment about those, what treatment or painkillers or remedies that you suggest? And then are there any injectables that you would pursue if the first few steps are not helping the patient?
Yeah. So supplements are, I think, kind of a individual preference. I tend to not really rely on supplements because they're not regulated. So we are buying things that we don't exactly know what they're contained. And also the doses aren't verified. So it's really hard to say, take this number of capsules for this type of relief. And everybody experiences pain and discomfort differently. So there isn't anything that regenerates the tissue to make the process go away. So that's what I tell patients first and foremost is like the underlying thing is going to be there. It just depends on what kind of band-aid you want to put on it to make it more tolerable, unless, of course, you're going to go have surgery and have the whole area changed. When it comes to osteoarthritis, I'm being specific about osteoarthritis. So there have been studies, there's scientific studies to show that turmeric does have anti-inflammatory effects, but they're at the sort of micro level. And I would say that really starts with like the GI microbiome membrane. So it's the way our body interprets inflammation signaling that triggers pain. So for some you have, let's say, dairy, for example, you get stomach upset and bloating. A lot of us understand that association because it's becoming more common. Or with celiac disease, you know that you cannot have gluten because it just makes your GI tract wreak havoc, right? And so a lot of times there's an association between what we eat and the way our body feels. So if we're eating things that don't make our body feel good, we're going to experience pain. And that pain may come in places where it doesn't seem like it's connected, right? Like, why does my knee hurt when I eat chocolate? Like, we can't say specifically, but it's a way that our body interprets pain from the types of food that we eat. So turmeric can lower inflammation on a very microscopic level, but it doesn't change anything. Same with the supplements, like glucosamine, we think it can help kind of lubricate, and collagen even, right? But it's something that changes the way our body interprets sensation and discomfort. It doesn't change the joint itself. So I'm not a huge proponent of recommending supplements because I think it's very easy to go down that rabbit hole, and then you start spending a lot of money on something that may have more of a placebo effect than an actual scientific alteration. So my biggest recommendation is really identifying if there are certain triggers that you associate, certain types of movements, right, that trigger your pain, certain behaviors that you do that irritate your joint a little bit more, and then certain foods that seem like it triggers like body-wide discomfort versus like localized tenderness. And that's gonna be a little bit better reliable relief for you than saying, take a supplement for 30 days and you're gonna miraculously feel better. We also kind of have to repeat the thing that's helping us feel good. When we treat your blood pressure is better when you're on medication. It doesn't automatically go away unless you fix the thing that was driving it to be high, like exercise, losing a body weight, things like that. So it's really hard to talk and stress about weight loss when we think about arthritis, but particularly in the knees, weight loss makes a big difference. It really does. And it can be as little as 5 pounds until you start to feel a change. And that's the load, right? Like if we carry a backpack with 15 pounds, our shoulders are going to feel that. So when we put on extra weight, particularly in the midsection or upper body, our knees feel that and, feel that pressure. And so alleviating that gravitational pull really does help. If you're walking off balance, so if you invert your foot or tilt it outward, your knee has to compensate. So a lot of patients forget to think about their feet when their knees bother them, but it something as simple as the way that you're rotating your foot. So if you had an injury to your foot, right? You had a surgery, you had your ankle fixed. Your balance is going to be different after that injury because you compensate for that. So then your knee over time is going to change its tilt because you're compensating from the way your foot balances. So it's all these things over time, right? And we can't just fix that alignment and reverse it. Those are like subconscious mechanical things that we do with our body that we don't even think about. So, in combination with weight loss, sometimes that can shift our mechanics because women in particular have a lot of knee pain because of the way our pelvis is rotated. If our thighs are thicker and our body, it pushes our legs outward, our knees buckle in. So, I'm not saying everyone has to be thin, but when we walk with a pillow in between our legs, right, that doesn't feel balanced. But when we force that change to happen over years, we don't know it's happening. It's just, this is just my body. But your knees are tilting to accommodate for that. Another thing that's really common in women in particular is what we call hypermobility. So when you have increased flexibility and you can actually like lock your joints, that backwards pressure on the knee over the course of your lifetime puts more pressure on the natural balance and alignment of your knee. And so you can have a lot of knee pain just purely based on the way that you stand, because if you're in the back of your knee, that puts more pressure on the front. There's things like patellofemoral syndrome where your kneecap can start to slide in and out when that patellar tendon is weak, which is usually related to weakness of the inner thigh muscles. So, big story for all of this is physical therapy to identify if you have an imbalance in your walk, in your body mechanics is really helpful as well. And that's going to give you better tools over the course of your lifetime than a supplement would. It's rebalancing your body. Because again, if we think about driving on a spare tire, let's say we do that for a day till we can get to the tire shop. Okay, fine. Not much damage is going to happen. If we do that for 2 years, our car is gonna be a wreck. It was not meant to be wobbly like that. So if we're expecting our body to just adapt over time, there's gonna be shifts in our mechanics that we have to then deal with the repercussions of that later. So, again, like a supplement isn't gonna fix that. Things like Tylenol or, Aleve, ibuprofen, like over-the-counter pain relievers are helpful as long as it's okay with, your specific physician that you can take those products. I don't recommend just kinda starting an over-the-counter regimen because those things can increase risk of, kidney issues, liver issues, ulcers. Like, there's a lot of risks still in over-the-counter medication options, and so, they can be helpful for a short period of time or under physician guidance, but I think, talking about, like, a dedicated prescription regimen or what's a good dose for me and my body is always helpful, and then, people will ask for injections. There's more and more studies coming out to show that repetitive corticosteroid injections actually damages the joint more than doing them. So we get temporary relief, right? We get a nice big, dopamine, hit from the cortisol, the cortisone, the steroid, and the pain diminishes and then it just comes right back. It returns. I mean, some people will do, like, gel injections that kinda add, again, a little more cushion. So you're basically just putting, like, a gel material into that joint space and sort of padding it a little bit, right? Like, putting sitting on an inflatable cushion. It's like it alleviates pressure on your tailbone just for a while until the mechanics settle in and that area hurts again. So it's just sort of an artificial kind of, like, poof of fluid to open up that space a little bit. So it's not so much like grinding, but there's really not an anti-inflammatory effect to that. Some people will try low doses of some of our rheumatoid medications. There are studies trying to look to see, do medications that work in rheumatoid arthritis help with osteoarthritis also? And none of them are really showing, a humongous benefit that that's like the next biggest, greatest thing. I think, we all get kind of tired of hearing it, but the reality is staying a healthy weight the best that you can, the majority of your lifetime that you can, lubricating your joints with exercise, so movement, not necessarily high impact, but like low impact activity, stretching, all those things. Those are gonna be better than medicine per se, but for those of us that have pain where you just cannot function, right, then understandably, there's treatment options for that, but it's not gonna fix it.
Yeah, you summarized it. I was thinking that, okay, because the way you broke it down, which is very, very insightful. And I really love the description that came along with supplements. They would just serve as a band-aid. It's not like fixing the actual problem, which is happening over time, over the years. If nothing else is working and they've tried all these measures, that's where the replacement surgeries are done. Like that's where they get referred to orthopedic surgeons.
And there's different methods to doing that, again, depending on, like, what's actually happening, right? I mean, if you have a meniscal tear causing knee pain, even though we kind of associate that with arthritis, right? That's actual, like, damage to a structure that can be repaired. Knee replacement surgery, interestingly enough, though, doesn't fix our body's perception of pain. So, a lot of people have knee replacement, and then there's a lifetime of that too, right? Again, like, I know I'm kind of belaboring this car analogy, but it really is true, right? When we put tires on our car, they're only expected to last a period of time. So even a knee replacement's only expected to last a certain period of time. And if you're gonna put a heavier load on that, right, that time frame is gonna diminish a little bit. If you're expecting your body to do a lot more heavy lifting and a lot more strenuous activity, that joint might not necessarily last the full, length of time. So, it's so much osteoarthritis is, like, so unique to the individual, but yet it's a universal problem that we have. And I think one of the most fascinating sort of things I think about when it comes to arthritis is the blue zone cultures. So, what is it about those people that live in those societies where they have less destruction to their body because they have less diabetes, they have less heart disease, they have less dementia, they have less joint issues, right? They have less of every chronic thing that happens to general Americans. And the more and more we learn about their way of life, the more we recognize it's the entire system, right? It's the ecosystem, it's the mental aspect, it's the GI tract, it's their stress, their literal environment that they live in that all contributes to those things. And so if we just expect ourselves to be healthy and happy our entire lives, we have to think about what type of ecosystem we're living in. Are we living in an environment where our stress levels are controlled? Are we living in an environment where we're decreasing or, monitoring how much chemical we're putting into our body, how much, we're expecting our body to do? And it's all intertwined, and it all starts so early on that when we're 20, we think we're indestructible. When we're 30, we're kinda like, "I'm still indestructible, but I'm 30." And then when we're 40, we're like, "Ooh, yeah, maybe I'm not as indestructible." And then every decade, right, we're kinda like, "Ooh, I'm a little more stiff. I have more aches. I'm more this, I'm more that." And it's like, when we're 50, it really mattered a lot more when we were 20 how we take care of our body. What do we put into our body? How do we expect our body to perform? Like you mentioned the decades, right? Every decade, what are we expecting in the moment? What do we want out of ourselves in the moment? But how are we thinking about when I'm 70, I want to be able to get up from a squatting position? Well, you have to keep that your musculoskeletal system strong. You have to keep your brain strong and healthy, right? Like, have to pay attention to the types of food that you eat. And all those day-to-day choices, we don't think about how that's gonna affect us in a decade.
Exactly. Yeah. Loved it, Dr. Brittany, because you covered like the lifestyle interventions, the preventive aspect of it, treating early on, recognizing it even if we don't have symptoms. And I just loved the breakdown from starting to the finish about this common, the way you call it as universal condition, osteoarthritis. If our audience, if our physicians who are listening to it, or anyone watching the YouTube video, if they had to seek your care because you're available in multiple states and practicing in even in Northeast, how could they reach out in terms of getting a consultation or seeing you as a physician?
So I have a wonderful team of people in my clinic. Like you said, we have multiple locations. So summitrheumatology.com is how you find us. And, we're accepting new patients in all of our locations and happy to help support evaluation for all joints.
Yes, thank you. So you are keeping them mobile and active. Yeah, thank you, Dr. Panico.